Hi friends, welcome to Pharmacology. So today we are going to discuss about the pharmacology of diuretics, which includes the mechanism of action, pharmacokinetics, adverse effects, drug interactions as well as therapeutic uses of loop diuretics, thiazides, potassium sparing diuretics, carbonic anhydrase inhibitors and osmotic diuretics. Then regarding the anatomy and physiology of the kidney, I have already discussed in my previous video. Please go and watch so that you will get a continuation of diuretics. So, as you all know, what do you mean by diuretics? They are the drugs that promote diuresis, or else we can say that diuretics are the drugs that increase the volume of urine excreted. So, this diuretics increase the volume of the urine and often change its pH as well as the ionic composition of the urine and blood. So there are different classes of diuretics, okay, as we have already seen. So the diuretic effect of different classes of diuretics varies considerably depending upon the site of action. And these diuretics are most commonly used for the management of excessive fluid retention, that is edema. And some of the diuretics can also be used for non-diuretic indications, which includes use of thiazides in hypertension, use of carbonic anhydrase inhibitors in glaucoma, and use of aldosterone antagonists in heart failure. First, we will see about the normal regulation of fluid and electrolytes by the kidney. We know that nephron is the functional unit of kidney, and this nephron consists of mainly two compartments or two components, that is the renal corpuscle as well as the renal tubule. The renal tubule consists of mainly three parts, that is PCT, proximal convoluted tubule, loop of Henle and distal convoluted tubule. Approximately 16% to 20% of the blood plasma entering the kidneys is filtered from the glomerular capillaries into the Bowman's capsule. The filtrate, although normally free of proteins and blood cells, contains most of the low molecular weight plasma components like glucose, sodium bicarbonate, amino acids and other organic solutes, as well as electrolytes such as sodium, potassium and chloride. The kidney regulates the ionic composition and volume of urine by active reabsorption or secretion of ions and or passive reabsorption of water at five functional zones along the nephron. Okay, that we already mentioned. That is the proximal convoluted tubule, then the loop of Henle. The loop of Henle has got two segments, that is the descending loop as well as the ascending loop, then the distal convoluted tubule and the collecting tubule and the duct. Proximal convoluted tubule. It is located in the cortex of the kidney, and in PCT almost all the glucose, bicarbonate, amino acids and other metabolites are reabsorbed. Approximately 65% of the filtered sodium and water is reabsorbed here. Chloride enters the lumen of the tubule in exchange for an anion such as oxalate as well as paracellularly through the lumen. The sodium that is reabsorbed is pumped into the interstitium by the Na plus K plus adenosine triphosphatase pump, that is Na plus K plus ATPase pump. So this is the lumen, that is nothing but the urine, and this is the interstitium or the blood. So sodium that is reabsorbed is pumped into the blood with the help of the transporter or Na plus K plus ATPase pump. Carbonic anhydrase in the luminal membrane and cytoplasm of the proximal tubular cells modulate the reabsorption of bicarbonate. Okay, so the reabsorption of bicarbonate is done with the help of carbonic anhydrase enzyme. Then despite having the highest percentage of filtered sodium that is reabsorbed, diuretics working in the proximal convoluted tubule display weak diuretic properties. Okay, so here we have already seen that is in PCT approximately 65% of the sodium, filtered sodium and water is reabsorbed. Okay, in spite of this, the diuretics acting on PCT display only weak diuretic properties. And one more important point regarding the proximal tubule is that it is the site of the organic acid and base secretory systems. The organic acid secretory system, located in the middle third of the proximal tubule, secretes a variety of organic acids such as uric acid, some antibiotics and diuretics from the bloodstream into the proximal tubular lumen. The organic acid secretory system is saturable, and diuretic drugs in the bloodstream compete for transfer with endogenous organic acids such as uric acid. Because of this, a number of drug interactions are possible, and one of the most common example is the interaction between probenecid and penicillin. Probenecid is a drug that can be used for the treatment of gout. So this probenecid interferes with the penicillin secretion. Now, the organic base secretory system located in the upper and middle segments of the proximal tubule is responsible for the secretion of creatinine and choline. So the next segment after the proximal convoluted tubule is descending loop of Henle. The remaining filtrate, which is isotonic, next enters the descending limb of the loop of Henle and passes into the medulla of the kidney. So an isotonic solution means it is a solution that having the same solute concentration as the another solution. Okay, so the filtrate entering the descending loop of Henle is isotonic. Then the osmolarity increases along the descending portion of the loop of Henle because of the countercurrent mechanism that is responsible for water reabsorption. This results in a tubular fluid with a threefold increase in sodium and chloride concentration. That is, the filtrate will become hypertonic. Okay, so the filtrate entering the descending loop of Henle is isotonic. Okay, isotonic means that having the similar or same solute concentration, then the water will be reabsorbed from the descending loop of Henle. So water will be reabsorbed means the concentration of water will become less and the concentration of solutes will be more. That will lead to increase in the osmolarity and the filtrate will become hypertonic. Okay, hypertonic means the tubular fluid with threefold increase in sodium and chloride concentration. Osmotic diuretics exert part of their action in this region, that is in the descending loop of Henle. And the next segment is the ascending loop of Henle. And one unique feature of this ascending loop of Henle is it is impermeable to water. And here what will happen? There will be active reabsorption of sodium, potassium and chloride. It is mediated with the help of Na plus K plus 2Cl minus cotransporter. Also, both magnesium and calcium are reabsorbed via the paracellular pathway. So what do you mean by paracellular pathway? It refers to the movement of molecules between the cells. Okay, between the cells means in between the spaces between the epithelial cells rather than directly through the cells themselves. Okay, so this both magnesium and calcium are reabsorbed via the paracellular pathway. That means in between the cells. Approximately 25% to 30% of the filtered sodium chloride is absorbed here. And this ascending loop of Henle is the major site for salt reabsorption and no segments distally are capable of significant sodium and water reabsorption. Drugs affecting this site such as loop diuretics have the greatest diuretic effect. So the loop diuretics are mainly acting on the ascending loop of Henle, which has got the highest diuretic action. So we have seen about the PCT, ascending and descending loop of Henle. Next is the distal convoluted tubule. So the cells of the distal convoluted tubule are also impermeable to water. About 5% to 10% of the filtered sodium chloride is reabsorbed via a Na plus Cl minus transporter, which is the target of thiazide diuretics. So here you can see the DCT cell or the distal convoluted tubule cell, and this is the Na plus Cl minus transporter through which the sodium and chloride are reabsorbed into the blood. And one more thing, calcium reabsorption also takes place in the DCT. Calcium reabsorption under the regulation of parathyroid hormone is mediated by an apical channel and then transported by a Na plus calcium exchanger into the interstitial fluid. So in DCT, sodium, chloride and calcium are reabsorbed. Calcium reabsorption under the regulation of parathyroid hormone. Moving on to the collecting tubule and duct. The principal cells of the collecting tubule and duct are responsible for Na plus K plus and water transport, whereas the intercalated cells affect the H plus secretion. So the collecting tubule consists of mainly two types of cells, that is the principal cell as well as the intercalated cell. The principal cells are responsible for sodium, potassium and water transport, whereas the intercalated cells affect the hydrogen ion secretion. Approximately 1% to 2% of the filtered sodium enters the principal cells through epithelial sodium channels that are inhibited by amiloride and triamtrene. Once inside the cell, sodium reabsorption relies on a Na plus K plus ATPase pump to be transported into the blood. Blood means that is the interstitium. So aldosterone receptors located in the principal cells influence sodium reabsorption and potassium secretion. Potassium secretion means potassium is secreted into the lumen and sodium is reabsorbed back into the blood. Antidiuretic hormone, also known as ADH or vasopressin, binds to V2 receptors to promote the reabsorption of water through aquaporin channels. In this slide, you can see the summary of major segments of the nephron and their functions. The major segments including the glomerulus, PCD, then loop of Henle, then distal convoluted tubule as well as the collecting duct. And what all are their functions? Okay, what all are the things and how much percentage of electrolytes are reabsorbed? Electrolytes and water are reabsorbed. Okay, that you can see here. Then how about the water permeability, whether it is permeable or impermeable? Then which all are the transporters involved? And the diuretics with their major action. So this image will help you to easily understand the site of action of various diuretic drugs. So starting with PCT or proximal convoluted tubule, carbonic anhydrase inhibitors and osmotic diuretics act in this area. Both of them have got weak diuretic action and osmotic diuretics are rarely used for diuresis. Then descending loop of Henle. This is site of action for osmotic diuretics which is rarely used for diuresis. Then the third segment is ascending loop of Henle, which is a site of action for loop diuretics which has got the strongest diuretic action. Then the distal convoluted tubule. It is a site of action for thiazide diuretics which has got a weak diuretic action. Then moving on to the last segment, that is the collecting tubule and duct. The drugs or the medications acts on this site includes aldosterone antagonist. They have got a weak to moderate dose dependent diuretic action. Then epithelial sodium channel antagonist. They have got the weakest diuretic action. And last one is vasopressin 2 receptor agonist. They have got moderate aquaporesis action. And the two most important sites are ascending loop of Henle, which is a major site of action for loop diuretics. Then the distal convoluted tubule, which is a site of action for thiazide diuretics. And the collecting tubule and duct, site of action for aldosterone antagonists. Now, regarding the classification of diuretics. Diuretics can be categorized into mainly five. That is thiazide diuretics, loop diuretics, potassium sparing diuretics, carbonic anhydrase inhibitors and osmotic diuretics. Now, let's see the examples that comes under each category. Thiazide diuretics, chlorothiazide, hydrochlorothiazide, chlorthalidone, intapamide, metolazone. Loop diuretics examples include furosemide, torsemide, bumetanide, ethacrynic acid. Potassium sparing diuretics include spironolactone, eplerenone, triamterene, amiloride. Carbonic anhydrase inhibitors examples include acetazolamide, dorzolamide, brinzolamide, and osmotic diuretics example is mannitol. First, we will see about the thiazide diuretics. They are also known as benzothiazines based on their chemical structure. Most widely used diuretics because of their antihypertensive effects. These agents also reduce peripheral vascular resistance with long-term therapy. Despite being sulfonamide derivatives, thiazides do not generally cause hypersensitivity reactions in patients with allergies to sulfonamide antimicrobials such as sulfamethoxazole. Thiazide diuretics are sometimes called as low ceiling diuretics because increasing the dose above normal therapeutic doses does not promote further diuretic response. Hence, these thiazide diuretics are also known as low ceiling diuretics. Hydrochlorothiazide is more potent, so the required dose is considerably lower than that of chlorothiazide. But the efficacy is comparable to that of the parent drug. More potent means lesser dose is required to produce that a particular action. Chlorthalidone is approximately twice as potent as hydrochlorothiazide. Chlorthalidone, intapamide and metolazone are referred to as thiazide-like diuretics. Okay, so the examples for thiazide-like diuretics include chlorthalidone, intapamide and metolazone because they lack the characteristic benzothiazine chemical structure. However, their mechanism of action, indications and adverse effects are similar to those of hydrochlorothiazide. Mechanism of action. As we have already seen, the site of action of thiazide diuretics is distal convoluted tubule. So this thiazide and thiazide-like diuretics act mainly in the distal convoluted tubule to decrease the reabsorption of sodium by inhibition of Na plus Cl minus co-transporter. As a result, these drugs increase the concentration of sodium and chlorine in the tubular fluid. Okay, so in a nutshell, we can say that the mechanism of action of thiazide diuretics is that they will inhibit Na plus Cl minus co-transporter in the distal convoluted tubule and thereby decrease the reabsorption of sodium, or else we can say that these drugs will increase the concentration of sodium and chloride in the urine or in the tubular fluid. Thiazides must be excreted into the tubular lumen at the proximal convoluted tubule to be effective. Therefore, decreasing renal function reduces the diuretic effects. The antihypertensive effects of thiazides may persist even when the glomerular filtration rate is below 30 ml per minute per 1.73 meter square. However, hypertension at this level of renal dysfunction is often exacerbated by hypervolemia, requiring a change to loop diuretics for volume status and therefore blood pressure control. The efficacy of thiazides may be diminished with concomitant use of non-steroidal anti-inflammatory drugs. So this is a major drug interaction. So, okay, drug interaction when there is a concomitant use of thiazides as well as NSAIDs. So what will happen? When these drugs are combined together, the efficacy of thiazides will be decreased, especially NSAIDs such as indomethacin, which will inhibit the production of renal prostaglandins, thereby reducing the renal blood flow. Because of this reduced renal blood flow, the efficacy of thiazides will be decreased when these drugs are concomitantly administered with non-steroidal anti-inflammatory drugs. Pharmacological actions of thiazide diuretics. The first and important one is increased excretion of sodium and chloride. So this thiazide diuretics can result in the excretion of very hyperosmolar urine, that is highly concentrated urine. This later effect is unique as the other diuretic classes are unlikely to produce a hyperosmolar urine. And the second one is decreased urinary calcium excretion. So this thiazide diuretics decrease the calcium content of urine by promoting the reabsorption of calcium in the distal convoluted tubule where parathyroid hormone regulates reabsorption. As we have already seen that in the distal convoluted tubule, the calcium reabsorption is under the regulation of parathyroid hormone. And the third action is reduced peripheral vascular resistance. An initial reduction in blood pressure results from a decrease in blood volume and therefore a decrease in cardiac output. So with continued thiazide diuretic therapy, blood volume returns to baseline. However, antihypertensive effects continue, resulting from reduced peripheral vascular resistance caused by relaxation of arteriolar smooth muscle. Therapeutic uses of thiazide diuretics includes hypertension, heart failure, hypercalciuria, and diabetes insipidus. So hypertension, clinically thiazides are a mainstay of antihypertensive treatment because they are inexpensive, convenient to administer and well tolerated. Blood pressure can be lowered with a daily dose of thiazide. Chlorthalidone is considered a preferred option by some clinicians because of its longer half-life ranging from 50 to 60 hours and improved control of blood pressure over the entire day. Next is heart failure. Loop diuretics are the diuretics of choice in reducing extracellular volume in heart failure. However, thiazide diuretics may be added in patients resistant to loop diuretics with careful monitoring for hypokalemia. Metolazone is most frequently utilized as an addition to loop diuretics. Then the next use is hypercalciuria. Thiazides can be useful in treating idiopathic hypercalciuria and calcium oxalate stones in the urinary tract because they inhibit urinary calcium excretion. Then diabetes insipidus. Thiazides have the unique ability to produce a hyperosmolar urine, that is highly concentrated urine. Thiazides can be utilized as a treatment for nephrogenic diabetes insipidus. Coming to the pharmacokinetics of thiazide diuretics, thiazide diuretics are orally effective with a bioavailability of 60 to 70%. Chlorothiazide has a much lower bioavailability, that is 15 to 30%, and it is the only thiazide with an intravenous dosage form. Remaining all others are orally available. Most thiazides take 1 to 3 weeks to produce a stable reduction in blood pressure and exhibit a prolonged half-life, approximately 10 to 15 hours. Indapamide differs from the class because it undergoes hepatic metabolism and it is excreted in both the urine and bile. Most thiazides are primarily excreted unchanged in the urine. Now moving on to the adverse effects of thiazide diuretics, which includes hypokalemia, hypomagnesemia, hyponatremia, hyperuricemia, hypovolemia, hypercalcemia, and hyperglycemia. So among these, hypokalemia is the most frequent problem with the thiazide diuretics because thiazides increase sodium in the filtrate arriving at the distal tubule. More potassium is exchanged for sodium, resulting in a continual loss of potassium from the body with prolonged use of these drugs. So therefore, serum potassium should be measured periodically, more frequently at the beginning of the therapy to monitor for the development of hypokalemia. potassium supplementation or combination with a potassium sparing diuretic may be required. Low sodium diets blunt the potassium depletion caused by thiazide diuretics. Then hypomagnesemia, which means urinary loss of magnesium. Then hyponatremia. This may develop due to elevation of antidiuretic hormone as well as diminished diluting capacity of the kidney and increased thirst. Then hyperuricemia. So thiazides increase serum uric acid by decreasing the amount of acid excreted through competition in the organic acid secretory system. So being insoluble, what will happen? This uric acid deposits in the joints and may precipitate a gouty attack in predisposed individuals. Therefore, thiazide should be used with caution in patients with gout or high levels of uric acid. Now, the next adverse effect is hypovolemia. This can cause orthostatic hypotension or lightheadedness. Then hypercalcemia, that you already know. The thiazides inhibit the secretion of calcium, sometimes leading to hypercalcemia. And the last one is hyperglycemia. Therapy with thiazides can lead to mild elevations in serum glucose, possibly due to impaired release of insulin related to hypokalemia. So patients with diabetes still benefit from thiazide therapy but should monitor glucose to assess the need for an adjustment in diabetes therapy if thiazides are initiated. Moving on to the next category, which is loop diuretics, also known as high ceiling diuretics. Major diuretic action on the ascending limb of loop of Henle. Of all the diuretics, these drugs have the highest efficacy in mobilizing sodium and chloride from the body, producing copious amounts of urine. Similar to thiazides, loop diuretics do not generally cause hypersensitivity reactions in patients with allergies to sulfonamide antimicrobials such as sulfamethoxazole because of structural differences in their sulfonamide derivative. The use of bumetanide and torsemide is increasing as these agents have better bioavailability and are more potent compared to furosemide. Ethacrenic acid is used infrequently due to its adverse effect profile. Mechanism of action of loop diuretics. So this loop diuretics inhibit the co-transport of Na plus K plus 2Cl minus in the luminal membrane in the ascending limb of the loop of Henle. Therefore, reabsorption of these ions into the renal medulla is decreased. So in a summary, we can say that this loop diuretics mainly act on the thick ascending limb of loop of Henle and they are Na plus K plus 2Cl minus co-transporter inhibitors, and they have got the greatest diuretic effect of all other diuretics because the ascending limb accounts for reabsorption of 25 to 30% of filtered sodium chloride and downstream sites are unable to compensate for the increased sodium load. Loop diuretics must be excreted into the tubular lumen at the proximal convoluted tubule to be effective. Non-steroidal anti-inflammatory drugs inhibit renal prostaglandin synthesis and can reduce the diuretic action of loop diuretics. Now regarding the pharmacological actions of loop diuretics. So the first and most important one is diuresis. This loop diuretics cause diuresis even in patients with poor renal function or lack of response to other diuretics. Then this loop diuretics display a sigmoidal or S-shaped dose response curve with three parts: a threshold, a rapid increase in diuresis with small changes in drug concentration, and a ceiling effect. So here you can see the loop diuretic dose response curve, which is a sigmoidal shaped or S-shaped dose response curve which has got three parts. That is a threshold effect, then a rapid increase in diuresis, and the third part is a ceiling effect. So a dose must be selected to cross the response threshold which is patient specific. Next one is increased urinary calcium excretion. Loop diuretics increase the calcium content of urine. In patients with normal serum calcium concentrations, hypocalcemia does not result because calcium is reabsorbed in the distal convoluted tubule under the regulation of parathyroid hormone. And the next pharmacological action is venodilation. Prior to their diuretic actions, loop diuretics cause acute venodilation and reduce left ventricular filling pressures via enhanced prostaglandin synthesis. Therapeutic uses of loop diuretics include edema, hypercalcemia, and hyperkalemia. So edema, loop diuretics are the drugs of choice for treatment of pulmonary edema and acute or chronic peripheral edema caused from heart failure or renal impairment. Because of their rapid onset of action, Particularly when given intravenously, the drugs are useful in emergency situations such as acute pulmonary edema. Hypercalcemia. Loop diuretics along with hydration are also useful in treating hypercalcemia because they stimulate tubular calcium excretion. Hyperkalemia. Loop diuretics can be used with or without replacement intravenous fluid for the treatment of hyperkalemia. Moving on to the pharmacokinetics, loop diuretics can be administered orally or parenterally. Furosemide has unpredictable bioavailability of 10% to 90% after oral administration. Bumetanide and torsemide have reliable bioavailability of 80% to 100%, which make these agents preferred for oral therapy. The duration of action is approximately 6 hours for furosemide and bumetanide and moderately longer for torsemide, allowing patients to predict the window of diuresis. Adverse effects of loop diuretics includes acute hypovolemia, hypokalemia, hyponatremia, hypocalcemia, hypomagnesemia, ototoxicity, hyperuricemia, and hyperglycemia. So, under acute hypovolemia, loop diuretics can cause a severe and rapid reduction in blood volume with the possibility of hypotension, shock, and cardiac arrhythmias. Then, hypokalemia. The heavy load of sodium presented to the collecting tubule results in increased exchange of tubular sodium for potassium, leading to hypokalemia, which is the most common adverse effect of loop diuretics. The loss of potassium from cells in exchange for H plus leads to hypokalemic alkalosis. So use of potassium sparing diuretics or supplementation with potassium can prevent the development of hypokalemia. Then urinary loss of magnesium can lead to hypomagnesemia. Then ototoxicity is the reversible or permanent hearing loss which may occur with loop diuretics, particularly when infused intravenously at fast rates, at high doses, or when used in conjunction with other ototoxic drugs, for example, aminoglycoside antibiotics, cisplatin, carboplatin, etc. With current dosing and appropriate infusion rates, ototoxicity is a rare occurrence. Ethacranic acid is the most likely to cause ototoxicity. Although less common, vestibular function may also be affected, inducing vertigo. Then hyperuricemia. Loop diuretics compete with uric acid for the renal secretory systems, thus blocking its secretion and in turn may cause or exacerbate gouty attacks. So here I have included some of the major drug interactions associated with thiazide and loop diuretics. So the first one, furosemide, which is a loop diuretic, or thiazides when combined together with digoxin. Digoxin is a cardiac glycoside. So what will happen? These diuretics cause hypokalemia, which increases the binding of digoxin to Na plus K plus ATPase, leading to digoxin toxicity. Okay, so this combination will lead to digoxin toxicity. And the second interaction is furosemide and aminoglycosides when given together. Both are ototoxic drugs and can cause enhanced ototoxicity when used together. Next one is furosemide or thiazides when given in combination with NSAIDs, that is non-steroidal anti-inflammatory drugs. So these NSAIDs inhibit prostaglandin synthesis and block the prostaglandin mediated hemodynamic changes. The chronic use of NSAIDs led to sodium and water retention and decreases the antihypertensive effect of loop diuretics or thiazides. And the next interaction is in between furosemide or thiazides and lithium. Lithium is a drug that can be used for the management of mania or bipolar disorder. So this diuretics cause hyponatremia and there is a compensatory increase in the reabsorption of sodium in the proximal convoluted tubule. Since lithium has a sodium dependent reabsorption, its reabsorption also increases, leading to lithium toxicity. Moving on to the next category of diuretics, that is potassium sparing diuretics. So under this we can see there are two main subcategories, that is aldosterone antagonist and epithelial sodium channel blockers. These drugs act in the collecting tubule to inhibit sodium reabsorption and potassium excretion. Potassium levels must be monitored in patients treated with potassium sparing diuretics, and these drugs should be used cautiously in moderate renal dysfunction and avoided in patients with severe renal dysfunction because of the increased risk of hyperkalemia. Aldosterone antagonist examples include spironolactone and eplerenone. So these drugs are synthetic steroids that antagonize aldosterone receptor. So first we will see what is the action of aldosterone, how it will act. So this aldosterone enters the cell and binds to a specific mineralocorticoid receptor in the cytoplasm of late distal tubule and collecting duct cells. The hormone receptor complex enters the cell nucleus where it induces the synthesis of aldosterone induced proteins. The net effect of aldosterone induced proteins is to retain sodium and excrete potassium. So what does spironolactone and eplerenone do? They are aldosterone antagonists. Okay, so these drugs competitively blocks the mineralocorticoid receptor and prevents the formation of aldosterone induced proteins. So therefore, spironolactone and eplerenone promotes sodium excretion and potassium retention. Spironolactone is most effective when circulating aldosterone levels are high. It also increases calcium excretion. Okay, so in a nutshell, we can say that these drugs prevents translocation of the receptor complex into the nucleus of the target cell, ultimately resulting in a lack of intracellular proteins that stimulate the Na plus K plus exchange sites of the collecting tubule. Thus, aldosterone antagonists prevent sodium reabsorption and therefore potassium and hydrogen secretion. Eplerenone is more selective for aldosterone receptors and causes less endocrine effects, that is gynecomastia, than spironolactone, which also binds to progesterone and androgen receptors. So one of the advantage of eplerenone over spironolactone is that this eplerenone causes less endocrine effects compared to spironolactone. Moving on to the pharmacological action, these drugs antagonize aldosterone receptors at renal sites which causes diuresis and non-renal sites which causes other effects. In most edematous states, blood levels of aldosterone are high, causing retention of sodium. Spironolactone antagonizes the activity of aldosterone, resulting in retention of potassium and excretion of sodium. Therapeutic uses include edema, hypokalemia, heart failure, resistant hypertension, polycystic ovary syndrome. So the first one, that is edema. Aldosterone antagonists are particularly effective diuretics when used in high doses for edema associated with secondary hyperaldosteronism such as hepatic cirrhosis and nephrotic syndrome. Spironolactone is a diuretic of choice in patients with hepatic cirrhosis with fluid in the peritoneal cavity, that is ascites. Next is hypokalemia. These agents are often given in conjunction with thiazide or loop diuretics to prevent potassium excretion that occurs with those diuretics. Next is heart failure. Aldosterone antagonists are employed at lower doses to prevent myocardial remodeling mediated by aldosterone. Use of these agents has been shown to decrease mortality associated with heart failure, particularly in those with reduced ejection fraction. And the next one, most important use is resistant hypertension. Resistant hypertension defined by the use of 3 or more medications without reaching the blood pressure goal often responds well to aldosterone antagonist. And the next use is polycystic ovary syndrome. Spironolactone is often used off-label for the treatment of polycystic ovary syndrome or PCOD. It blocks androgen receptors and inhibits steroid synthesis at high doses, thereby helping to offset increased androgen levels seen in this disorder. About the pharmacokinetics, both spironolactone and eplerenone are well absorbed after oral administration. Spironolactone is extensively metabolized and converted to several active metabolites. That is, one of the active metabolites is candrenone, which contribute to the therapeutic effects. Eplerenone is metabolized by cytochrome P450, that is CYP3A4. Now, this potassium sparing diuretics, mainly this aldosterone antagonists, have two major adverse effects, that is hyperkalemia and gynecomastia. Hyperkalemia is the most common side effect. It is dose dependent and increases with renal dysfunction or with concomitant use of other potassium sparing agents such as AC inhibitors, angiotensin converting enzyme inhibitors and potassium supplements. And the next adverse effect is gynecomastia. It is commonly seen with spironolactone but not with eplerenone. Spironolactone but not eplerenone may induce gynecomastia in approximately 10% of male patients and menstrual irregularities in female patients. Under potassium sparing diuretics, the next category is epithelial sodium channel blockers. Examples include triamtrene and amloride. So these drugs resulting in a decrease in sodium or potassium exchange. Although they have a potassium sparing diuretic action similar to that of the aldosterone antagonist, their ability to block the Na plus K plus exchange site in the collecting tubule does not depend on the presence of aldosterone. Like the aldosterone antagonist, these agents are not very efficacious diuretics. Both triamcinolone amiloride are commonly used in combination with other diuretics, almost solely for their potassium sparing properties. So under diuretics, the next category is carbonic anhydrase inhibitors. Examples include acetazolamide, dorzolamide, brinzolamide, etc. So these drugs are more often used for their other pharmacological actions than for their diuretic effect because they are much less efficacious than the thiazide or loop diuretics. Then regarding the mechanism of action, from the name itself it's clear. Okay, they are carbonic anhydrase enzyme inhibitors. So these drugs inhibits carbonic anhydrase enzyme located intracellularly, that is in the cytoplasm and on the apical membrane of the proximal tubular epithelium. So the function of this carbonic anhydrase enzyme is to catalyze the reaction of carbon dioxide and water leading to the formation of H2CO3. So here you can see the reaction. Okay, H2O plus CO2 in the presence of carbonic anhydrase enzyme, H2CO3 will be formed, which spontaneously ionizes to H plus, that is hydrogen ions, and HCO3 minus, that is bicarbonate ions. The decreased ability to exchange sodium for H plus in the presence of acetazolamide results in a mild diuresis. Additionally, bicarbonate is retained in the lumen. That is, bicarbonate will be more in the lumen. Lumen means in the urine. So, with marked elevation in urinary pH, if there is an increased amount of bicarbonate, that will lead to increase in the urinary pH. Okay, so urine will have a normal pH is there. So if there is an excess presence of bicarbonate, that will lead to increase in the urinary pH. The loss of bicarbonate causes a hyperchloremic metabolic acidosis. Therapeutic uses of carbonic anhydrase enzyme inhibitors include glaucoma and altitude sickness. So glaucoma means it decreases. In glaucoma, what these carbonic anhydrase enzymes will do? These drugs decreases the production of aqueous humor and reduces the intraocular pressure in patients with chronic open-angle glaucoma, probably by blocking carbonic anhydrase in the ciliary body of the eye. Topical carbonic anhydrase inhibitors such as dorzolamide and brinzolamide have the advantage of not causing systemic effects. And the next use is altitude sickness. Acetazolamide can be used in the prophylaxis of symptoms of altitude sickness. Acetazolamide prevents weakness, breathlessness, dizziness, nausea, and cerebral as well as pulmonary edema characteristic of the syndrome. And other than this, the acetazolamide can be used to alkalinize the urine. Now regarding the pharmacokinetics, acetazolamide can be administered orally or intravenously. It is approximately 90% protein bound and eliminated renally by both active tubular secretion and passive reabsorption. Adverse effects. So one of the most important and main adverse effect is metabolic acidosis, that is mild, potassium depletion, then renal stone formation, drowsiness and paresthesia may occur. The drug should be avoided in patients with hepatic cirrhosis because it could lead to decreased excretion of ammonia, NH4+. And the last category of diuretics include osmotic diuretics. Examples are mannitol, urea, and glycerol. A number of simple hydrophilic chemical substances that are filtered through the glomerulus, such as mannitol, result in diuresis. Filtered substances that undergo little or no reabsorption result in a higher osmolarity of the tubular fluid. This prevents further water reabsorption at the descending loop of Henle and proximal convoluted tubule, resulting in osmotic diuresis with little additional sodium excretion. Therefore, these agents are not useful for treating conditions in which sodium retention occurs. They are used to maintain urine flow following acute toxic ingestion of substances capable of producing acute renal failure. So in a nutshell, we can say that regarding the mechanism of action, osmotic diuretics draw water from tissues by osmotic action. This results in increased excretion of water and electrolytes. Now regarding the therapeutic use, osmotic diuretics are a mainstay of treatment for patients with increased intracranial pressure. Other uses include mannitol is used to prevent acute renal shutdown in shock, cardiovascular surgery, hemolytic transfusion reactions, etc. And also it is used to reduce the elevated intracranial tension following head injury or tumor. It is used both pre and post operatively to reduce the elevated intraocular pressure in acute congestive glaucoma. And also mannitol is used to produce diuresis in case of poisoning. For example, acute barbiturate poisoning. Then mannitol is not absorbed when given orally and should be given intravenously. Regarding the adverse effects, dehydration and extracellular water expansion from the osmotic effects in the systemic circulation. The expansion of extracellular water occurs because the presence of mannitol in the extracellular fluid extracts water from the cells and causes hyponatremia until diuresis occurs. So in this slide, you can see the urinary excretion from diuretic therapy. Here you can see the different diuretic classes and what will happen to the urine volume and what are the electrolytes that will be excreted through the urine. Suppose in case of thiazides, here you can see one difference. Okay, there will be decreased urinary excretion of calcium. Okay, so here see the difference. And whereas in case of loop diuretics, there will be increased urinary excretion of calcium. Okay, likewise, you can refer this image regarding the urinary excretion, regarding the urine volume and what are the electrolytes that are excreted or reabsorbed. So with this slide, we have completed the pharmacology of diuretics. If you find this video informative, please like, share and subscribe. Thank you everyone for watching this video. Have a great day.